What promising treatments are available for patients facing an RMC diagnosis?
Although RMC carries a guarded prognosis because of its aggressive nature and because of its rarity, we have been able to change this bleak outcome, change the prognosis over the past, I would say, decade. From, back in the 90s and 2000s, early on, patients, unfortunately, with RMC, unfortunately, lived only a few months because people didn't know how to treat it. And it requires the knowledge, to build the knowledge. That's important infrastructure that really builds the program, that it's the little things that matter that ultimately in aggregate improves the survival. So chemotherapy is available everywhere. People can get chemotherapy in even small cities, hospitals that have chemotherapy that treat patients with other common cancers like breast cancer and lung cancer and colon cancer. Chemotherapy is available, but it's not just, having chemotherapy on the shelf in a pharmacy. So there are urologists, surgeons that operate on patients with cancer, in good hospitals, but it's not enough. And it's not, you need to put all those things together. It's like a board with pieces of the puzzle. You just have to really have the knowledge to put these pieces together, to know when to operate, when not to operate, to know what chemotherapy to give and when to give it. And there are advances. We're making those advances, but chemotherapy remains the mainstay for now in 2023 and in 2022 and prior for the last several years, as long as I've been at MD Anderson. We came up with the first-line chemotherapy regimen that has been our first-line backbone for treatment of patients with RMC and have been successful in it. Unfortunately, not every patient responds to it, but a good number of patients will respond to it. And we can build on that chemotherapy with further chemotherapy. And we have some newer therapies that we are developing. We have some clinical trials. I am very hopeful and optimistic about the future, but chemotherapy remains the mainstay for first-line therapy. So a patient with RMC needs to start chemotherapy. There are two drugs that we've used, and I've used them on Herman, as you will know, Taxol or paclitaxel and carboplatin. Unfortunately, not every patient with RMC is going to benefit from this for a long time, but this will be the start. I think it's very important for a patient with RMC that has, especially if they have spread of their cancer outside the kidney, to not have the surgery up front. That's not wise. It is important to start with the chemotherapy only after the patient achieves an excellent response to the chemotherapy, where you control the disease in these organs or other sites outside the kidney. Then one can proceed and remove the kidney, as we did with Herman. We gave him the chemotherapy first. He had a fantastic response. We were able to remove his right kidney. And there was a very minute focus of residual cancer in the right kidney, I remember. But even then, we had to go back and give him chemotherapy afterwards. But beyond chemotherapy, we have newer therapies that we are exploring. Dr. Masao in my group, on my team, has been leading some of these trials. And we believe that we have some key targets that we have identified that are relevant for RMC, that we are developing novel, we hope, more effective therapies in the future. Only through clinical trials, we're going to make progress. So my activation tip is chemotherapy is good, but we hope to develop more effective therapies in the future. So my activation tip is, please, engage, enroll, participate in clinical trials. Only through research we can advance the field and ultimately conquer this devastating disease.